I am so excited to have NEJM's Editorial Fellowship Program as a sponsor for this podcast. Hear from Dr. Sarah Gorey, an NEJM Editorial Fellow, on what qualities that would make this opportunity really align.
It comes down to three main things. So the first thing I think is, are you curious? If you're the kind of person who's, why do we do that? And why don't we do something else? I think that curiosity is key. The second thing I think is communication. Are you passionate about communicating the reason behind what we do, the science, the evidence, get communicated clearly, that we're accountable, that it's true and it is, the best quality evidence is being presented, because the people who work at the New England Journal of Medicine are incredibly passionate about making sure that science is accurate and it's communicated in the clearest possible way. And then you're a sponge. Do you want to learn? Do you want to just sit and soak up the wisdom, the experience, the knowledge that people have in this environment? So for me, those three things, if you have those skills, you would really enjoy the fellowship.
So if you're curious, have a love of communication, and want to learn as much as possible, the 1-year full-time paid editorial fellowship may be right for you. Check out the show notes for the link and learn more about the program and the application.
Hi everyone, welcome back to another episode of Hoofbeats. I'm Cindy Fain, a hospitalist at NYU.
And I'm John Huang, Cindy's colleague at NYU.
We're going to do something a bit different this episode. You will hear a real case presented to you as though we are at the M&N conference. Your first challenge is, as usual, to diagnose the patient. But your second challenge, and the real reason we are here, is to diagnose the physician. Why might they have struggled to think of the right diagnosis in the real world?
Here to present the case is our Core AM colleague, Dr. Shreya Trivedi.
Our patient is a 72-year-old male who presents with 2 weeks of abdominal pain, decreased appetite, and an 8-kilogram weight loss in the last 2 to 3 months. He has a past medical history significant for high blood pressure, hyperlipidemia, a recovered cardiomyopathy with a normal ejection fraction from remote cocaine use, and remote hepatitis B 40 years ago. He initially had normal vital signs. Physical exam was significant for focal right upper quadrant pain. Workup and admission was notable for a high white count, leukocytosis to the 20s, normal renal function, an AST of around 300, an ALT around 400, alkaline phosphatase in the 700s, and then hyperbilirubinemia with a total bilirubin of 4 and a direct bilirubin of 3, an INR of 1.4, and a lactate that ranged from 4 to 7 despite a trial of intravenous fluids. Imaging studies, unfortunately, but unsurprisingly, revealed numerous greater than 20 liver masses with pancreatic, renal, and pelvic bony lesions. The radiologist also commented that the liver overall is somewhat micronodular with volume distribution compatible with chronic parenchymal liver disease, which raised the concern for multifocal primary hepatocellular carcinoma. He underwent IR-guided liver biopsy on hospital day 3, and on the morning of hospital day 4, he became newly but persistently tachycardic to the 120s to 130s. At that time, he was afebrile with stable blood pressures in the 110s over 50s.
Let's stop here for a moment. So new onset tachycardia. What do you think is going on? Our discussant for today's case is Dr. McQuaid. Dr. McQuaid is a hospitalist at the University of Pittsburgh and the director of the clinical reasoning curriculum there. A few years ago, I attended a conference held by the Society to Improve Diagnosis in Medicine and was fascinated by his work on problem representation. So naturally, I begged him to come on to our show.
An older gentleman who's pretty sick at baseline comes in late into a presentation of metastatic disease. He's already sick when he starts out. His risk of morbidity and mortality right from the door, right from admission, is going to be pretty high.
This is actually something I've been trying to do with my residents. I would be asking them, who's the sickest patient on your list? How are they going to die on you? What's your one-liner for quick care and that rapid response?
What you just described, Cindy, sometimes I think that's literally our core function, as hospitalists.
Professional paranoia?
Pre-mortem analysis, Cindy, I think would be the word. But essentially, yes, professional paranoia. Constantly trying not to be surprised, to be caught off guard.
And actually, Dr. McQuaid did a lot of this as he went through the case.
So this gentleman developed a tachycardia first. I would look at the telemetry, see if it's something that's sudden. If it's sudden onset, it's an arrhythmia, I would start worrying about pulmonary embolism as one of my prime candidates. If it's more gradual, like a sinus tachycardia, given that he's status post to procedure, I would worry that he's bleeding and he's getting worse because he's bleeding. Of the liver biopsies I had one in the past couple of years that the patient hemorrhaged afterwards and had to go to an ICU. So that, just from a recency bias standpoint or availability, because I've seen one, that would come to mind. Those would honestly be the first two emergent things I would think of, because they would be the most immediately life-threatening things for this patient. So having someone decompensate unexpectedly, or perhaps it's been dreaded and in some ways it's expected, it doesn't really surprise me. The problem is whenever it happens, then there's the rush to figure out what's going on. When someone is getting sick, thinking straight is hard, and reminding yourself to slow down and not just jump heuristically to the things that are going to kill them are sepsis, PE, and hemorrhage. We need updated data so we can update how we're representing the problem in our mind, draw a completely new problem representation so that we can figure out what our differential diagnosis is.
I notice it's almost like he's doing two premortems in parallel, actually.
Right. We're not only trying to anticipate how a patient might deteriorate, we're also trying to anticipate how we might go cognitively astray.
On exam, the patient's tachycardic, fatigue appearing, but otherwise no new findings on exam. His labs at this time showed a worsened leukocytosis to 38 from 20 with 11% bands. His hemoglobin was stable. His creatinine, unfortunately, rose to 2.2 from a normal baseline, and with a BN up to 53. He also had a new metabolic acidosis with a pH of 7.16, a bicarb of 10, and a lactate of 16. Repeat labs within 2 hours were done and showed a rising creatinine to 2.9, and by this point, he had become oliguric.
So it looks like we've reached a turning point here, Cindy.
Yeah, let's pause here. Listeners, what do you think is going on? What would you have done at this point? We'll hear it from Dr. McQuaid after the break.
Sepsis can do this, and in the case, you cover him very well, very broadly. Start out with piptazo. I think that covers most things unless he has a resistant organism. He has a history of HFrEF, and for stress or other reasons, he could go back into low output heart failure, especially with an arrhythmia. Cardiogenic shock can present with normal and abnormal blood pressures. The only thing that was kind of puzzling to me reading it was the way that the image was read. So it said greater than 20 liver masses and mets in different places. And they said concerning for possible metastatic hepatocellular carcinoma. That's a trap because the radiologist has taken a firm stand on something, which I applaud them for. When they're that firm, I always have to remind myself that, okay, they're positing hepatocellular carcinoma, but what else would be on the differential? So I'd actually be worried about other things that can go to the liver, like GI cancers, colon cancer goes to the liver, lung goes to the liver, liquid malignancy like leukemia or lymphoma can do just about anything.
Cindy, at this point, I don't think you can put it off any longer. It's time for you to come clean with our listeners.
Yeah, I'm going to own up to this now. So this case was actually my patient from a few years ago.
So it just occurred to me that you really threw Shreya under the bus. You made everyone think that this was her M&M.
Well, I can't host and present.
Sure. So then, you're going to tell us what happened next.
Yeah, we treated him for sepsis. We gave intravenous fluid. We started broad-spectrum antibiotics to cover everything intra-abdominal, and we co-crit cared. As part of the process to escalate his care, and figuring that we would soon be having a goals of care conversation, I called the pathology lab to check on the liver biopsy to see if there was anything preliminary that might give us more information about his prognosis. And to my surprise, they told me high-grade B-cell lymphoma. And then it was only when I was looking up the pager number for the hematology consult that the diagnosis of tumor lysis syndrome finally crossed my mind.
So you checked the labs?
Yes.
And what was the uric acid?
It was 19.
Oh dear.
The upper limit of normal in our lab is 8, by the way, and the LDH was undetectable. By that, I mean undetectably high, like greater than 2500. On the bright side, the phosphate and potassium were only mildly elevated in the low 5s.
And you didn't find any other contributing processes?
No, all cultures were negative. Hemoglobin remained stable. Echo was unchanged from prior. We moved him to the MICU and started continuous renal replacement therapy and chemotherapy. But unfortunately, in spite of the treatment, he progressed to multi-organ failure. He ultimately passed away in hospice care 11 days after he was admitted. So to this day, I'm still shocked that tumor lysis syndrome did not occur to me, or at least did not occur to me until the diagnosis of a liquid tumor was confirmed. Why did it escape me?
I know that pain, Cindy. I've had to ask myself this question more times than I'd care to admit. And I think it can be a deceptively simple question. There's evidence to suggest that we're relatively good at recognizing when we've made a mistake, but we're not necessarily good at identifying what is responsible for those errors.
Yeah, that's what I see at M&M conferences sometimes, and I remember struggling with it as a resident. Saying something like, well, I missed the diagnosis because I committed anchoring bias, or I prematurely closed down sepsis, or I was carried away by diagnostic momentum, or I failed to consider a broader differential. Saying these never left me feeling like I was getting to the root of the problem.
Or with an obvious solution.
I mean, what should be my takeaway here?
For the sake of making a point here, I'm going to be deliberately obnoxious. How about just don't anchor? Be thoughtful, not overconfident. Get good.
Oh, trust me. I mean, besides frantically calling the ICU, I was asking myself and everyone around me 100 times, what else could it be? Because I had no clue what was going on. I was the opposite of being overly confident.
So taking a diagnostic timeout didn't help your anchoring?
Nope.
I just thought of another obnoxious takeaway. Have a high index of suspicion for tumor lysis syndrome. How about that?
Well, if that's the lesson I should take from every M&M conference, then I should have a high index of suspicion for lymphoma, but also TB and sarcoid and syphilis and pulmonary embolism. The list of cannot miss diagnoses and great mimickers just goes on and on.
Right. Not really helpful.
So this is why I sat down with our discussant. I wanted to ask Dr. McQuaid how he would diagnose me.
I am so excited to have Echo Core 500 digital stethoscope as a sponsor. I actually learned about them accidentally a year or so ago when I'd forgotten my stethoscope and my resident let me borrow his, and I just was like, wow, I have never heard heart sounds or lung sounds this clearly. You just get this extra level of confidence for those moments where you're asking, was that faint crackles? Was that an S3 gallop? And so that's because Echo's digital stethoscope amplifies sounds 40x, and then on top of that, it has noise cancellation so you can really hear with precision in a noisy ED or with a really loud roommate or other environments. Echo AI is also built in and helps you detect murmurs and AFib earlier. A cool thing also is that you can record that heart sound that you heard, share it later with your team, or on a case presentation. And then you can really trust the diagnostic accuracy. It's backed by 4 million heart sounds and 8 FDA clearances for the devices and the AI algorithms. So those who use Echo are twice as likely to catch heart disease. What I think is neat is that Echo 500 isn't just the digital stethoscope. You can actually also get an EKG tracing right on the app when you place an Echo 500 on a patient's chest. So no more waiting around trying to trace down the EKG machine on the floor. I trust Echo so much that I work with a team to create a special offer just for our listeners. Right now, you can get $50 off plus a free customizable chest piece cover at echohealth.com/corium. Your purchase will be HSA and FSA eligible and may also qualify for CME reimbursement. Plus, Echo guarantees you're going to detect heart and lung sounds more confidently, and if you don't, you can return it with a full refund. Go to echohealth.com/corium for $50 off plus a free chest cover. That's ekohealth.com/corium. And with that, let's get back into the episode. Let's be real, it can be hard to eat healthy without feeling like you're giving up flavor or fun. And one of my favorite freezer finds that checks all the boxes is frozen Washington red raspberries. They're grown with care by American family farmers in Washington state. They're picked at peak ripeness and frozen within hours so you get that natural, delicious flavor, and they're always in season. There's no added sugar. They're packed with nutrients. It's only 80 calories a cup, 8 grams of fiber, a great source of vitamin C, folate, low glycemic index. I love tossing them into my morning smoothies or putting them in yogurt. It tastes so fresh. And also, I just feel good that in the morning, there's something that I'm starting my day with that's real, and better knowing that I'm supporting local U.S. farmers with every bag. And so you can find Washington red raspberries at Costco, Kruger's, Wine Co. Foods. Just look for product of the U.S. on the label on the bag. They're even in things that you might already love, like Kirkland's 3-berry blend, Smucker's raspberry jam, and those Uncrustables with raspberry filling. So visit redraz.org. You can find recipes, health tips, retail locations near you. That's redraz, redrazz.org. And with that, let's get back to the episode.
If I had seen everything in the back from like the backwards view, of course you say, oh, this is a patient who was diagnosed with lymphoma and was admitted to the hospital with abdominal pain, and their creatinine escalates rapidly. And oh my goodness, this is very clearly an error in knowledge about tumor lysis syndrome, when that might not actually be the case. A lot of, quote, cognitive biases could be reinterpreted as lesions of recalling the right data at the right time. So it's actually a knowledge deficit or a knowledge organization deficit. And I'm a big believer in that. I think if knowledge is king, then knowledge organization is the queen of the kingdom. Because if you have all of the knowledge and you can't access it, you may as not, why have the knowledge? You're not going to be able to use it when you need it.
Instead of naming a cognitive bias, I'm glad the first thing in his mind was, is it a knowledge deficit or is it a different problem? This is how he thinks about diagnosing defects in the reasoning process. It's like he's providing a structured approach to localizing the cognitive lesion.
Sort of like a diagnostic schema, but for diagnosing error.
Yes. His schema, we heard, starts by asking, was it a gap in knowledge? Is it something that I did not know about tumor lysis syndrome? Or was it how I organize what I do know about tumor lysis syndrome?
So if you went through this process, Cindy, what did you end up concluding, about yourself?
Well,
do you know what TLS is, Dr. Fang?
I think I do, Dr. Huang.
So it's not a knowledge gap.
Well, if we can be serious for a moment, I do think there's a problem with my illness script for tumor lysis syndrome. Do you remember how in a previous episode we talked about the activation of illness script isn't always a conscious act?
Yeah, I do. It's more like recognition rather than conscious identification.
And the recognition relies heavily on context. So I wonder what would have happened if this patient was not admitted to a general medicine bed, but instead to the oncology floor.
Geography is destiny, like everyone gets tumor lysis labs as soon as they go to an oncology floor.
Yeah, exactly. Even if I firmly believe that this patient had a solid tumor, if we were on the oncology floor, tumor lysis syndrome would have come to mind 3 times a day for every single patient. If this patient was boarding on the cardiology floor, I probably would have immediately considered a malignant pericardial effusion as the cause of his tachycardia.
So it sounds like the solution here is to post signs in the call room saying, "Attention house staff, admit everyone with liver masses to an oncology floor," so that I will remember to think about TLS. Sounds good?
Sounds amazing. We should do that. But my actual point is, I think the fact that context was so crucial is another example that the activation of illness scripts can often be involuntary and out of our control, which is exactly why we need effective and flexible illness scripts to make it easier to retrieve the correct ones in the right clinical context.
Obviously I agree that our scripts need to be effective, but curious, Cindy, what you mean by effective. We've talked on this show before about how illness scripts have 3 components, right? The enabling conditions, so who the patient is, the fault, right? What's going wrong, and the consequence, the manifestations of the illness. So where are you thinking that your illness script for TLS was ineffective?
Well, the fact that I needed lymphoma, a liquid tumor, as a prerequisite enabling condition, makes me think that my illness script for TLS was way too rigid.
Like just in the context of malignancy, you get over the HCC thing in your mind, and then you start saying progressively worsening AKI in a malignancy. This is something deep in my brain, an illness script that's being triggered, and I don't know if it fits because it's the wrong malignancy because the HCC idea is still there.
Right. But even if I was convinced that he had a solid tumor, TLS still should have been something I considered. After this case, I went back and reviewed my understanding of TLS and reminded myself that even though it's rare, tumor lysis syndrome can happen in solid tumors, especially if the tumor in question is bulky and metastatic.
I was also reading, it can happen if it's just been irradiated, chemoembolized, even just biopsied.
Oh, and apparently, as bad as tumor lysis syndrome can be in liquid tumors, it carries an even worse prognosis when you see it in patients with solid tumors. We're not quite sure why, but it's been postulated that only patients with high-grade solid tumors with high tumor burden and rapid cell turnover rate develops tumor lysis syndrome. Well, needless to say, the enabling condition for my illness scripts on TLS now includes all kinds of cancers, liquid and solid.
So, shifting gears a bit, we've been talking about activation of illness scripts, Cindy, but didn't you say you knew Dr. McQuaid through his work on problem representation? Did he have any comments for you on that?
Well, it doesn't take Dr. McQuaid, the expert, to point out that I did not have a good problem representation for this patient at the time. Well, I wasn't even trying to solve the right clinical question. I was so focused on the tachycardia and the uptrending lactate and the metabolic acidosis instead of his oligouric acute kidney injury. And I know we said many times already, you cannot get to the right answer by solving the wrong problem.
Of course. Although everyone knows how hard that is when you're juggling more than one problem.
In the moment, ultimately, the way the case plays out is the tumor lysis syndrome becomes very important to the patient, but you have to prevent cardiovascular collapse first. That actually does take precedence. So you were solving the clinical problem that was most deadly to the patient, which oddly enough was just as meaningful as the AKI clinical problem.
Now, I know Dr. McQuaid is saying this to make me feel better. But yeah, at the time of a rapid response, who cares about the kidneys?
That's a next week problem. Sorry, nephrology listeners.
Well, I'm pretty sure no nephrologists are listening to our podcast. But Dr. McQuaid pointed out why I was ignoring the right problem, because I had limited cognitive bandwidth at the time, and I decided to not spend it on his kidneys.
Hang on, Cindy. So time is all you think that you needed? Like, are you saying if you had had unlimited time to think about the kidney injury, you would have eventually thought of TLS?
I mean, if I had unlimited time, I would have to be smart enough to use that time to rephrase my problem representation around the acute kidney injury first.
Right, that makes more sense to me. So slowing down itself would not have helped. It's what you do with the time after you slow down.
And then I would have to not blame that AKI on the borderline hemodynamic instability. So if I had to guess, having a good schema for AKI in place would have helped me. A schema that includes, besides hemodynamic instability, all the other important causes of ATN, including tumor lysis syndrome, rhabdomyolysis, contrast nephropathy, etc., etc. So a more productive takeaway for this case would be to revisit my schema for AKI and making sure that tumor lysis syndrome is firmly in place.
So what might seem at a glance like a time crunch problem is actually better thought of, or more productively thought of, as a knowledge organization problem, just like our discussant suggested earlier.
Our discussant has some other suggestions for me on how to improve my problem representation in this case.
And what you would have to have done, Cindy, I think, is You would have had to known about the labs because I think there are a ton of reasons for someone's creatinine escalating. Bleeds, malperfusion of something from a PE, getting sick from sepsis. Without the other electrolytes being wonky, I don't know that I would have jumped to tumor lysis syndrome alone. But you could have, and what you would have had to have done with just the creatinine is you would have had to have said to yourself, have a progressively worsening AKI in a patient with a malignancy. That's your problem representation, the name of the problem in the appropriate context with the temporal modifier. Stopping and doing that and representing that problem in that context in the moment is hard. It's doable, but you can say a progressively worsening AKI in a patient with a recently diagnosed and widespread malignancy. It's doable, but you have to unthink a lot of things first.
Yeah, and that was another mistake I made. I labeled this patient in my mind as someone with metastatic cancer, most likely hepatocellular carcinoma or some kind of unidentified solid tumor, instead of leaving it broad like, well, it's just someone with cancer.
That's the idea behind semantic qualifiers. You process the clinical information, yet keep it abstract and generalizable. We get that balance right, and it becomes more likely that our brains can link the case to our illness scripts.
I mean, when you say it like that, it seems so obvious. But it's so much easier said than done.
Another thing that's supposed to get better with practice, they say.
Well, they say that, but instead of just asking me to practice to get good, this is what Dr. McQuaid did to diagnose the root cause of my mistake.
The challenging thing is you have to put yourself in that person's shoes. And that gets hard because, say even you just start with an H&P, Cindy. An H&P is a very curated document. Someone has sat down and they've decided what's important, what's not important, what order to put things in, what things to emphasize. And it's laid out a lot like an essay or like a legal document. Someone is, whether they're doing it deliberately or not, they're constructing an argument in that. And so the way I do it is I try to approach it as I would approach a patient. I start with the chief complaint, and I try to think about, if I'm doing a sort of cognitive autopsy like we're doing for this case, and I start with the chief complaint and think about where would I be led first. If you try to go through the case prospectively, you'll see yourself fall into traps. When you look at things going from a forward perspective, you can see, when you get that radiology read, your brain is in a lot different space, and my differential contains a lot different issues because it's anchored on that radiological interpretation. The only thing that was kind of puzzling to me reading it was the way that the image was read. So said greater than 20 liver masses and Mets in different places. And they said concerning for possible metastatic hepatocellular carcinoma. That's a trap. I always have to remind myself that, okay, they're positing hepatocellular carcinoma, but what else would be on the differential? So I'd actually be worried about other things that can go to the liver, like GI cancers, colon cancer goes to the liver, lung goes to the liver. Liquid malignancy like leukemia or lymphoma can do just about anything.
And he was right. The way that radiology study was presented to you is misleading. I have to be honest, I only gave you the first few lines of the radiologist's impression, but if you scroll further down, the whole paragraph actually reads, quote, differential includes hepatocellular carcinoma, metastatic cancer of unknown primary, and possible lymphoma.
Okay, Cindy, this is not a CPC. You can't just hide critical information to make the case more challenging.
Well, here's another confession. The day the patient decompensated was actually the day I rotated on service, so I barely met him before everything started crumbling in front of my eyes. I don't remember if I reviewed the entirety of that CAT scan report, but my understanding of the clinical picture was that this is someone with some kind of metastatic solid tumor, most likely HCC.
So the erroneous abstraction from greater than 20 liver masses with renal bony lesions to metastatic HCC, you're saying that stems from an incomplete understanding of a piece of crucial radiology data.
Well, I know that sounds really bad. Just reading the first line of the radiology impression is such a rookie mistake. And I could have blamed it on, lack of time and shift turnover and all that jazz, but it might have been more than that.
Cognitive load is very real. That's why I think this is why we have developed problem representation. It's like an adaptation to the high cognitive load that we see when we take care of any patient, let alone a hospitalized high acuity patient. And building that problem representation from scratch generates a high cognitive load that you just can't handle when you're picking a patient up for the first time and they've all of a sudden become very sick.
When someone is getting sick, thinking straight is hard. And reminding yourself to slow down and not just jump heuristically to the things that are going to kill them are sepsis, PE, and hemorrhage. And that's where okay, someone's decompensating. This is why we get a new set of labs, because it gives us a bunch of data to start triggering new illness scripts for ourselves. So we don't just rely on our gut instinct. Also because we need updated data so we can update how we're representing the problem in our mind. Draw a completely new problem representation so that we can figure out what our differential diagnosis is.
There, Dr. McQuaid diagnosed my biggest problem. Knowing myself, my brain craves certainty and a concrete diagnosis in a hectic situation like a rapid response. That's probably why I was rushing to process raw data too quickly and jumping to early conclusions. Metastatic HCC was so much more satisfying and easier for my brain to handle than malignancy and OS.
It's not just your problem, Cindy. I think it's human nature. There's a lot of evidence to suggest that our brains are wired to avoid uncertainty, and that we will do some pretty illogical things to accomplish that.
Well, now that I know this is the kind of mistake my brain is predisposed to, Dr. McQuaid suggested the perfect actionable item for me. Next time I need to do a timeout in a hectic situation, I'm going to work on taking that time to intentionally reviewing my data and updating my problem representation accurately.
So I've been listening to your conversation with Dr. McQuaid, Cindy, and something else that stands out to me is how he bases his critique of your thought process by thinking in parallel with you, asking for the information sequentially, rather than getting everything at once and then offering his retrospective thoughts.
Oh, yeah. Do you remember that study where a bunch of experts were asked to identify cognitive biases in a resident's reasoning process? And of course, they identified twice as many biases when they were told the resident got the wrong diagnosis, even though the thought process under examination was exactly the same.
This is the fun thing about cognitive biases and heuristics. They're heuristics and they're helpful when things go well, and they're biases when things don't go well. So everything that you're doing is your brain trying to help you out, and that's okay until something goes wrong. And then in retrospect, we say it's a bias. So it's very easy for me to opine about these things after the fact.
It's a very conscious decision on his part to avoid teleologic criticism.
Mm-hmm. And by doing that, he gave me personalized coaching that helped me develop all these actionable items that we mentioned earlier in the episode.
All of the studies where we've tried to educate people about cognitive biases don't improve the rates that people end up exhibiting biases. Unfortunate, but true. I do think that individual people's internal cognitive processes, like everyone thinks in a particular way. We all come to conclusions in our own way, at our own speeds, because our own internal schemas, the way that we organize data in our brains, is different, and it's based off of our own experiences. And so for me, I think that I am particularly prone to certain types of biases, like premature closure when it's some types of complaints, like abdominal complaints. Hate GI issues, don't know why, always have. So I want to exclude the ambiguity from my mind, and I want to come to a diagnosis quickly because I don't like thinking about the gut. Whereas I love thinking about the heart and can talk about that all day, and the lungs as well. So I know for me, my own personal bias is going to be closing too quickly whenever I'm thinking about a particular type of problem. So what I coach people to do is to learn how you think.
I think the key takeaway I'm learning from Dr. McQuaid here is that everyone's brain works differently. The manner we orient ourselves in the world of diagnostic uncertainty, how we navigate the sea of data, how we calibrate the trade-off between speed and accuracy, is affected by so many factors, including our personal experience and, quote, ambient conditions like the clinical setting and context. The resulting reasoning pathway or the cognitive disposition to response is very different for everyone.
Agreed. And that's why simple self-admonishment to stop anchoring is not going to work. Right? Everyone is probably anchoring for a different reason. Best to reflect on those reasons rather than just the behavior.
And to reflect on how things have gone wrong, I must first explore and understand my personal cognitive disposition. And then from there, I can derive my personal actionable items that I can work on, either by expanding my scope of knowledge or improving my knowledge organization. All right, listeners, that should do it for this episode.
Remember, if you have a case you'd like to submit for discussion, or someone you'd like to come on and hear as a discussant, please get in touch with us. Visit our website at www.coreimpodcast.com or send us an email at hello@coreimpodcast.com. We are also on Facebook and Twitter at @coreimpodcast.
I want to say thank you again to our discussant, Dr. McQuaid.
And special thanks as well to Drs. Amy O, Shreya Trivedi, and Marty Fried, along with our other Core IM colleagues.
And as an honorable mention, as always, to Dr. Stephen Liu.
Opinions expressed in this podcast are our own and do not represent the opinions of other affiliated institutions, nor should they be construed as medical advice.
Thank you again for joining us. With Core IM, I'm Cindy Fain.
And I'm John Huang. See you next time.
With so many options, why choose Arizona State University?
For me, the only online option was ASU because of the quality. Their faculty was really involved with their students and care about your personal journey. The dedication to my personal development from my professors, that's been extremely valuable to me.
Earn your degree from the nation's most innovative university. Online. That's a degree better. Explore more than 350 plus undergraduate, graduate, and certificate programs at asuonline.asu.edu.
Life is a workout, and Smoothie King is here to help you power through. Whether you're grinding out bicep curls or muscling the couch across the living room, crushing morning miles, or sprinting through back-to-back meetings, Smoothie King has fuel to help you maximize your workouts, own your recovery, and elevate your game. Give your body the energy, protein, and power it needs with a lineup of delicious smoothies made to help you conquer your goals. Only at Smoothie King.